development of gastric cancer? And then when do we test and treat for Helicobacter pylori infection? So as mentioned by Dr. Ayman, the gastric cancer incidence in Saudi Arabia is not uncommon. So it's 2.7 per 10,000, and it's ranked the 15th cancer in Saudi Arabia, compared to the 6th, also ranked worldwide. The most common type of gastric cancer is adenocarcinoma, it's around 90%, followed by multiple lymphoma, carcinoid, and gastrointestinal stromal tumor, and the least common is the hereditary diffuse gastric cancer. Helicobacter pylori infection is the main risk factor for gastric cancer. So this bacteria is a gram-negative spiral-shaped bacterium that colonize normally in the gastric epithelium. And the prevalence rate among symptomatic patients in Saudi Arabia range between 50 to 80%. And in a recent meta-analysis that showed the global prevalence of H. pylori in the world is 44%. So most patients are asymptomatic. However, the cumulative lifetime risk of peptic ulcer disease in those patients is 10 to 15%. And the risk of gastric cancer range between 0.5 to 1% and can go up to 3% in some areas in the world, like the Eastern countries in Asia. So this figure shows the outcomes of Helicobacter pylori infection, and we can see the thickness of the arrow that indicate the incidence of each outcome. So most commonly it presents as mild pangastritis, and most of patients are asymptomatic or just have dyspepsia, followed by antral involvement that can lead to duodenal ulcer, and then corpus involvement, which has higher risk of precancerous lesion. And the least common outcome is the mild lymphoma, which can be seen endoscopically as only mild pangastritis. So what about the pathogenesis? The main two factors in the pathogenesis is chronic inflammation of the stomach and the Helicobacter pylori virulence factors. The chronic inflammation can involve direct effect on the gastric epithelial cells, which lead to oxidative stress, and also they found it can cause a DNA repair impairment, which can lead to the carcinogenesis pathway. The other mechanism is activation of the adaptive immune system and release of multiple cytokines that can lead to cancer eventually. The virulence factors, there are multiple in the H. pylori that can help the bacteria to survive in the gastric acid, make the bacteria more attached to the gastric epithelium, and the most important ones are the ones that can cause tissue damage, specifically the VAC-A and the CAG-A factors, which involved in the carcinogenesis pathway. Histologically, adenocarcinoma divided into two types: intestinal, that can go through what called chorea pathway, atrophic gastritis, all the way to dysplasia and adenocarcinoma, or the diffuse type. And this has been subclassified in 2010 to different types of adenocarcinoma histologically, and they found that H. pylori associated with both the intestinal type that go through the metaplasia, atrophic gastritis, as well as the diffuse type that not necessarily involve the precancerous lesions as well. So these are multiple key epidemiological studies done in early 2000s that showed higher incidence of H. pylori in patients with gastric cancer, especially an association with non-cardia gastric cancer, and in patients with corpus predominant gastritis or intestinal metaplasia. We can see most of these studies done in Asia, in China and Japan. So what about in countries with less incidence of gastric cancer? And we can see that not all patients with H. pylori develop cancer, so there are other risk factors involved. This has been looked at in a large retrospective cohort study published recently among the US population, and they looked at more than 300,000 patients with H. pylori over 20 years. 0.5% developed adenocarcinoma over a follow-up with a median of 7 years. And they studied the risk factors in those patients, and they found that age, increment of 5 years for every 5 years after the diagnosis, the hazard ratio increased by 1.1. And then we can see the race. It's more common in African American and Asian racial changes, racial differences. And also the history of smoking with hazard ratio more than 1 has been associated with gastric cancer and H. pylori patient. So we can see in the first plot here, A and B, among the treated patient with H. pylori, treated patient for H. pylori, it was not associated with increased incidence of gastric cancer. And we can see in diagram B, in the population where eradication has been confirmed, the risk of gastric cancer was significantly lower. And in both groups, still smoking, the racial differences has been associated with higher incidence of gastric cancer. So the other risk factors, as mentioned in the earlier presentation, include smoking, ethnicity, obesity, certain type of diets. Family history play an important role, and they found that presence of family history as well as H. pylori infection increase the risk by 8-fold. And there is a theory that there are other bacteria involved in gastric adenocarcinoma, as H. pylori infection changed the microbiota in the stomach, and studies have shown increased abundance of certain bacteria in patients with gastric cancer and H. pylori infection compared to a normal stomach. So does the eradication of H. pylori prevent gastric cancer? Again, this has been looked in multiple studies that showed a benefit of treatment and in patients with H. pylori that prevent cancer. So studies have shown benefit in patients with normal stomach, like the first study by Wong in 2004, but more recent that showed also benefit in prevention, even in patients with intestinal metaplasia. So this controversial topic has been looked at in a meta-analysis in a group of patients only with intestinal metaplasia, and involved 8 randomized controlled trials. And it showed here in the group where there is intestinal metaplasia, the eradication did not decrease the incidence of gastric cancer. However, in the lower diagram, the forest plot, where there is no intestinal metaplasia, there was benefit from Helicobacter pylori eradication and decreased incidence of gastric cancer. This is more recent, a Cochrane review published in 2020, involved 7 randomized controlled trial, and it studied the proportion of patients who had gastric cancer and H. pylori eradication group compared to placebo group. And we can see in the pink column, the incidence of gastric cancer decreased in the H. pylori eradication group by 46%. And the number need to treat is 72 cases to prevent 1 gastric cancer. And what about the precancerous lesion and metaplasia? We can see the first forest plot, the upper one, that there is really no change in gastric cancer prevalence if there is intestinal metaplasia. The last study with this regard just published recently with a 20-year follow-up randomized controlled trial in 2 Colombian towns where the gastric cancer incidence is high. And they calculated the histology score for intestinal metaplasia for each patient, and 350 patients completed 20 years follow-up. All of them, they had intestinal metaplasia, and they assessed the risk of gastric cancer. And we can see here in the red dotted line where there is H. pylori patient, it was associated with worsening histological finding if there is H. pylori infection over 20 years. And the first 3 years, there was no change in histology in the treatment group or in the placebo group. After 3 years, start to get worse when there is H. pylori infection. And this is a nice diagram that showed the natural history of the intestinal metaplasia and the outcome over 20 years. We can see here in diagram A that 18% of incomplete type metaplasia after 20 years turn into dysplasia or cancer compared to only 2% of the complete type. And the same thing based on the location. When there is metaplasia in the body of the stomach, it has higher risk than the metaplasia in the antrum. And this table showed the effect of Helicobacter pylori eradication, and it was associated with regression of the intestinal metaplasia over time, which contradict the previous studies. So what about treatment if there is already cancer? So this has been looked up in the systematic review and meta-analysis published recently, the effect of Helicobacter pylori treatment in patients who underwent endoscopic resection for early gastric cancer, and included 14 studies. All of them showed decreased risk of metachronous lesion with Helicobacter pylori eradication after endoscopic resection. The same thing here. After gastrectomy, the treatment for Helicobacter pylori infection associated with improvement of overall survival as well as disease-free survival. And we can see here in the diagram better survival rate in patients who got treated with Helicobacter pylori infection post-surgical resection. Just a couple of slides about mild lymphoma. It's one of the most common type of lymphoma in the stomach, and there is a main role for H. pylori in mild lymphoma in all stages. And we can see endoscopically it can present starting from gastritis, mild, up to bad ulceration, and can be missed easily. So sometimes deeper tissue biopsy is needed. And here we can see the role of EUS in patients with mild lymphoma with high sensitivity and specificity. It allows a deeper tissue biopsy by fine needle biopsy, lymph node staging, and this is the most accurate test to assess deeper layer involvements. And this is important because staging will determine the type of treatment of mild, and we can see all stages of mild involve Helicobacter pylori eradication whenever it is positive, regardless of the stage. So when do we test and treat? So this is the most recent ACG guideline published last month.
Dr. Adel, 2 minutes.
Okay. So it showed the indications for test and treat in all patients who is symptomatic with uninvestigational or investigational dyspepsia, as well as previous history of peptic ulcer disease mild. And they also added that the household of all patients with H. pylori, all the household can be tested and treated, as well as patients with functional dyspepsia. I think in those two indications, we probably have to discuss risk and benefits of treatment in this type of patients. And just to add more, treatment should also include, or the test and treat should be also directed to all patients with high risk of gastric cancer, include the ones with precancerous lesion. So in conclusion, H. pylori infection has been associated with gastric adenocarcinoma and mild lymphoma. However, there are other risk factors along with H. pylori need to be addressed and managed if possible. And the H. pylori education associated with decreased incidence of gastric cancer, especially in normal stomach, gastritis, atrophic gastritis, and possibly, which is controversial, in precancerous lesion, which may suggest a point of no return once it's reached the stage of metaplasia and dysplasia. The evidence showed that eradication in patients with gastric cancer post-resection decreased the incidence of metachronous recurrence lesion as well as improved survival. And then whenever test is indicated, then eradication is recommended if it is positive. Thank you.